There are a few additional comments that I would like to make about the Nick Reiner case that are in response to other comments made by a forensic psychiatrist on Court TV, Carol Lieberman. What she said was that this particular case exposes the weaknesses of the mental health system. And at least on Court TV, she didn't elaborate on what she meant. But this is stuff that I have been aware of throughout my career, beginning in my internship, although it followed me later as I acquired even more information about how the mental health system works in a hospital facility and also even in the jail. For anyone beginning a psychology practice in a mental health institution, especially in a hospital, you will soon find that the hospital that you are beginning your work in is based on the medical model, and that the amount of participation you can have in treatment in that facility will vary very much depending on who you're working with. That will be up to the psychiatrist. And it's my impression after all these years that the role of psychology has diminished with minimal input on any treatment team, except in those rare exceptions where a psychiatrist knows whether a psychologist is able to contribute, which is probably the reason for Dr. Lieberman, that is Dr. Carol Lieberman's opinion that psychiatrists have been reduced to the role of pill pushers. For those who do not know it, psychiatrists' role primarily is to diagnose and to match up the medication that works with the diagnosis that they arrive at when they are treating a particular patient. While personal engagement with a patient might actually occur, it's my experience, even during the time that I worked inpatient, that it was rare. And I still recall that after 20 or 25 years, that the last time I worked inpatient, I would meet with patients on a regular basis individually. I would sit and I would talk with them and find out what their concerns were. But that until I actually went to the psychiatrist and expressed that there was a problem, nothing was of interest to them other than to maintain the medications over a period of time and to observe the effects of those medications. And then it was another Dr. Lieberman, Dr. Jeffrey Lieberman, who appeared on TMZ, who was the former president of the American Psychiatric Association. Responding to what was reported in the media, he stated that Nick Reiner's medications were changed in response to his complaint that he was gaining weight. That in itself is a point of interest because there would have to be some medical record to suggest that he was gaining weight in response to his medications as a side effect. And without that data, they would simply be responding to his complaint as a patient. There is no way to know how any of this is true except by reviewing the documentation of his weight at the time he began the medications, and if so, whether it was a known side effect of the medication, and whether there were any other side effects that might have been of concern both to the patient and to the treatment providers. Since all of this information was taken from the media, both information that I gathered from what I had read and seen online, along with both Doctors Lieberman, who also probably had the same sources of information to draw their conclusions, there still may be other factors that would lead one to conclude that there are weaknesses in the mental health system, as I observed during the time that I worked in it. But in my opinion, these weaknesses are systemic to the system and are not incidental to the people who are providing the services. As I previously described, the head of any treatment team in a psychiatric unit is the psychiatrist, and that the treatment is based almost entirely on the medical model. One obvious weakness in this system, as I was just describing, is that if all you're looking for is a diagnosis to match up with a medication treatment, you're really not going to fully explore the kinds of dynamics that would create the kinds of outcomes that would lead to someone like Nick Reiner murdering both his parents, with no obvious awareness of potential consequences once he got caught. And since he was taken into custody at the jail, it has been reported that he sees that everything that's happening to him now is part of a big conspiracy, and that he doesn't see anything wrong with having murdered his parents. In the last episode of this podcast, I made reference to the fact that his treatment by his parents, the kindness that they displayed to him even when he was probably acting out and was at his lowest, taught him how he needed to behave in order to achieve necessary goals. It suggests to me, although it's not conclusive, that he's a bit of a chameleon and has some knowledge of how to interact with others in order to get what he wants. Although at this point, with the trouble that he finds himself in, he's probably going to also learn that the people who are providing his treatment are not as easily manipulated as his parents were. And it may take him a while to realize that he's having to respond to an entirely new set of rules, and with the prospect that he may never be released from incarceration, whether it is in a correction facility or a mental hospital. But it was in response to the comments that I saw on the web from Dr. Carol Lieberman, the forensic psychiatrist, that made me think back on the earliest times in my training. And it made me feel like I didn't know whether to laugh or cry. I still recall that the head nurse on one of the wards where I was interning was talking about the good old days when any new admission was treated with a shot of Haldol in either cheek of the buttocks. This was one way to chemically enforce compliance, as the new patient would promptly be put asleep with the medications, and behaviors would quickly become manageable. For him, that was a time of nostalgia when he could think back on when things were easier on the ward and people could be kept in a much quieter condition without thinking specifically about how they could be treated or have their mental stability restored to them. That's not quite the same as the job of a psychologist, who is partly to understand the diagnosis and to find a way to engage with the patient in order to help stabilize them using more psychological tools than chemical. And without that kind of intervention, all that is left to the staff on a psychiatric ward is to essentially have the entire team, or those who are of muscular stature, get together and contain them, and to lock them in a room where they're isolated from others. These brute force solutions, either through medications or through muscle, does little in order to improve a person's psychiatric condition, and it does not help improve diagnostics either, as they are quickly put to sleep and are easily managed once medications have been administered, or else when they are locked away with only a bed for companionship so that they can sleep whatever it is off. But I can't just blame psychiatrists or training in psychiatry for how patients are treated. Rather, even in my field, in psychology, if I think back, I can't think of very many courses that discussed how you can engage with the patients when you sit down and talk to them, especially if they don't have a strong connection to reality. So in a certain sense, it seems that the psychologist might not know what he or she is doing on a ward, either what their role is or how they can contribute to a treatment team in designing interventions that might help any particular patient, perhaps eventually releasing them either to the community or to a community program. The best that psychologists, including mental health counselors, have in order to know how to engage with people is usually what they learned about Carl Rogers' client-centered therapy. Although this approach was later extracted from the actual technique, which later became active listening skills, asking open-ended questions, reflection of feeling, giving encouraging nonverbal cues, paraphrasing, and suspending judgment. This is a good baseline for working with normal people in an outpatient environment, but when it comes to interacting with people with severe mental illnesses, it's not necessarily the best approach, especially in the case of inpatient treatment, where a patient's choices of action are extremely limited and their actions were so dysfunctional as to lead them to hospitalization. Talking therapy is not quite enough to help with stabilization, although it does contribute, and that is one of the things that tends to be overlooked. The first thing to look for when interacting with a patient, one who has been medicated and is stabilizing on the medication, is to assess for reality contact, to see how much they really understand the situation they were in and what they would need in order to be released from the hospital. To a psychologist, it's functioning a bit like a guide, orienting the patient to where the real world is, what kind of errors in thinking were made in order for them to be able to understand what they're doing in the hospital in the first place. Some people never get there, but for others, if properly medicated, then they may actually stabilize, and the recognition of that stabilization is made during the time that these kinds of discussions occur. But at this point, I'd like to present a situation that I experienced on my internship years ago that will illustrate the differences between psychological thinking and psychiatric thinking in a very dramatic way. I'll start by saying that I was still in the very beginning stages of finding my way around work at a mental hospital. Every day and almost every experience confounded me because I really didn't understand a sense of the totality of what was going on. There was so much contradiction even in the ward itself, and this was a hospital that I would describe at that time as being marginally in control of the patients. I won't be discussing a particular case, but my interaction with medical staff who were making decisions about patient treatment and giving me little participation in the process, although I will freely admit that I was so new that I really didn't know how I would contribute or could contribute at that time. Remembering, of course, if you listen to my last episode, that I didn't even know how to read a chart. But the situation was this. A new antipsychotic medication, Clozaril, was introduced around the country, and they were asking medical staff to monitor its effects on the various patients in the various hospitals around the country. And it was at the request of the medical director that the patients with Clozaril be monitored closely because there was the possibility of a side effect, a granular cytosis, which could have been deadly. If I had to do it over again with what I know now, I might simply step back and watch the show. But instead, I was encouraged to participate by an LPN on the ward who had conferred with other nurses before she approached me. Somehow she knew that I was the most likely sucker to go back to the medical director and explain that our psychiatrist had discontinued the use of Clozaril with his patients as soon as he could, as I later understood, because he was very afraid of what the side effects might be, and apparently was afraid particularly of a granular cytosis. I asked the nurse who approached me whether she had observed any improvements in the patients that she had worked with. And to be quite honest, the patients that were receiving Clozaril were so acutely psychotic that I couldn't tell the difference at that point whether the medication was helping or not. She gave me the assurance that the medication was helping, and she said that she was concerned that the psychiatrist, the head of our treatment team, was about to withdraw the medications because of his concerns that he might get sued for the side effects. Nevertheless, I did accept her report and her concern about the withdrawal of the medication, and I complied with what the medical director had said that we should do if we saw any problem with its administration. So I went back to the medical director's office and I explained the situation without having any particular interest in whether the Clozaril was continued or not, as I couldn't see what the effects were, not working directly with some patients who were so acutely psychotic that one built an altar on top of a trash can and set it on fire. Apparently, the medical director had a conversation with the psychiatrist on our ward, and the Clozaril was restored, both to help with the patient's increasing stability, but also so they could monitor the effects of the medication and have the data to feed back to the medication's developers. And there I was, among the most clueless of people working on that ward, with the least experience, having just arrived, and not even being able to read a chart, and even limited understanding about how to interact with people who are so severely psychotic, when I found myself sitting in the office, where all the charts were kept, with the psychiatrist who would be prescribing in that case, and was refusing to continue the Clozaril, and the head nurse. And so the psychiatrist said, almost under his breath, but certainly loud enough for me to hear, and he knew it, that if he ever found out who turned me in to the medical director, well, it was something physical that he threatened. I can't recall exactly what it was. And it was a threat that I summarily ignored. As they say, I had no skin in the game. I actually had no idea how many patients were now on Clozaril on our ward, and I wasn't even particularly paying attention to the patient that might have been of concern to the nurse. I literally have no memory for who it was, and I probably didn't document anything about the administration of the medication or its treatment or side effect. But as I said, I was well aware that we were part of an investigation to see the effectiveness of the medication, and that the medical director had a particular interest in getting useful data to feed back to the medication developer. Other than working with others within the system, I thought I was doing what needed to be done in order to carry my part of the load. But instead, I was being physically threatened, or at least the verbal threat of a physical pummeling, because I did what I did. As much as this tale describes my limited effectiveness in my role as a psychologist on a psychiatric ward with patients who had acute psychiatric problems. It also points to the problems that psychiatrists have and medical directors and the politics of being inpatient, at least in that facility. At the time, literally, there was nothing to beat me up about, as this psychiatrist threatened. I was not threatening his position, but trying to get the hospital the data that was wanted by the medication developer. Frankly, otherwise, I didn't care, although I did care about the nurse's report that a particular patient, someone that I hadn't really worked with and probably didn't even leave a note, had improved as a result of the administration of the meds. So you don't have to scratch too deeply to get below the surface to realize that the functioning of a dysfunctional hospital is not only for mental health considerations, but also for politics and fear of what might happen in the course of practice. But it doesn't necessarily focus on patient treatment or patient outcomes. I also learned during that period of time that transfers of patients from one ward to another were also highly political. And unfortunately, at the time, I approached it very much as an innocent. I truly didn't know that there were other wards that would be wanting to dump more aggressive patients on us just to get rid of them. And I would say to the psychiatrists now, if the same thing were to occur, I have no interest in how this thing plays out. I'm just trying to give the hospital the data that was requested so that we could play our role in the development of the treatment. So for psychology, the learning was not only in how patients are affected by the use of certain medications, whether some of the medications are not appropriately prescribed and symptoms get worse, but also that the people in charge of writing the scripts, the ones who make the med orders in order to treat the patients, have their own agenda, and they have all the power in the situation. Although, at least in this case, the psychiatrist didn't feel so comfortable as to take me outside and pummel me as he wanted to do. I will say in future treatment teams, I observed again and again how my input would be ignored, not only by the medical person in charge of any treatment, but also with the line staff, who probably had more experience in a hospital setting doing the hard hands-on work, and realized that the person in charge was the psychiatrist and the one who would make ultimate decisions in treatment. And between psychologist and psychiatrist, if we got along, the effects of what we were doing was also much greater and in a positive direction than it was when there was no interaction or limited interaction between the psychiatrist and the psychologist. Are we a team or aren't we? So if you place these kinds of dynamics in the situation in which Nick Reiner finds himself, if there are no psychologists on that unit, or there is only the psychiatrist, mostly the psychiatrist will feel that all obligations are fulfilled simply by making a diagnosis that may be accurate, or, as I suspect, only partially accurate, so that he or she could marry it up with the appropriate medication for that problem. There are issues of reality testing, improvement in medical or in mental condition as medications take effect, orientation of what is required when a patient leaves the hospital, and let me be clear, that is orientation for the patient, because once the gates are thrown open, they are out on their own, and if they don't have enough information for how to deal in the community with other people, then they will immediately be sent back to the hospital, having been unable to adapt to a community in which there is no structure and where they don't have the assistance of others to succeed, even to the most limited extent. So when Dr. Carol Lieberman said that the Nick Reiner case exposes the weaknesses of the mental health system, to me it is an understatement. Unless everyone can recognize who can contribute what, which various disciplines have things to add to a treatment team, and until the treatment team discovers an ability to act as a unit, things will fall apart, particularly for patients. Although it'll make things even more difficult for everyone on the team who are trying to effect a meaningful treatment. That is, if they are trying to accomplish that at all. In the cases I'm describing, this is not just weakness, the weakness of the mental health system, but actually a dysfunction that partly has to do with the fact that people who are trained in one area don't know at all how to interact with people who are trained in another area, and that the training itself sometimes are inadequate for someone to be able to effectively treat the severely mentally ill in a controlled environment. In future episodes, I will be discussing how psychology has gone astray, because I think it is important to understand what a person can expect when they go into therapy with a psychologist, and how they may be helped or not helped depending on who they work with. Once you get the PhD, there is nothing that is boilerplate in your treatment, except for our background and how we are told to do therapy. And clients or patients have to temper their expectations and be very clear about what they want from the experience. Until then, stay healthy, be well, and for God's sake, don't go crazy.